waiting time to pregnancy below 12 months, which is really very close to the waiting time to pregnancy in the general population. So our conclusion from that study was that the waiting time to pregnancy was really within what's reported for the general population in France. But we have to admit that there is a wide confidence interval because the data is only based on 60 or 70 women. In the paper, you can see that there was a low prevalence of infertility. And that suggests that really the women who had been treated with streptococcus in childhood had no adverse impact on fertility in adulthood. Of course, as I was mentioning, it's still early because 24 years is young. So maybe the same women at the age of 34 would certainly provide better data, and I think it's really important to keep doing these studies to accumulate more data. I'm not going to cover the cognitive and psychosocial function for the sake of time. I think that I still have a little bit time, so I'm going to present that very briefly. In terms of cognitive and psychosocial function, as part of the consensus, we could not make any firm recommendation, and there were no good controlled studies with standardized instruments. And basically, we are still at the same point. We did, and this is an unpublished study, a qualitative study on psychosocial aspect of precocious puberty to address the psychosocial impact of precocious puberty, uses qualitative method and semi-structured interview with the aim to construct a better tool. And what was quite interesting was that from these semi-structured interviews, we had different themes that were reported by both the patients, the mothers, and the fathers. And for instance, the breast development was really an important theme for the patients because they were often mocked for the early breast development. The menses were not reported by the patients, of course, because they don't know much about them, but was a matter of anxiety for the mothers. The social life was not a main issue as part of that study. Clearly, the precocious puberty generated more conflicts between the girls and mainly their mothers. And the rapid growth was, of course, quite well perceived in the short term, but there was a vague perception for the risk of short stature. To us, it was really important to do this study to understand why families are seeking treatment or why families are not seeking treatments. And we think it's a good approach to avoid, of course, over-treatment in this situation. So our conclusion is that we're quite happy with the tolerance and the results of the GnRH agonist therapy. We are still conscious that there is an overuse of GnRH agonists around the world, at least in France, and was not addressed today, but non-progressive precocious puberty should, of course, not be treated. The gray zone in terms of age is still an issue. And I'm not addressing today the issue of short stature. But of course, in true precocious puberty, these are really excellent treatment. And I want to leave you with the acknowledgement of our pediatric endocrine group at Robert Debré, including, of course, Julien Léger, who is our next speaker. So thank you very much for your attention.
Thank you very much for a very insightful lecture. Now it is Q&A question. I will start with Professor Park. He has few questions for both of you, I think.
Thank you for Professor Cleo's excellent talk. My first question is, as we know, rapid progression of puberty can compromise final adult height. My question is, how do we know in advance any predictors at the initial onset of puberty?
Predictors for which aspects? I didn't get your question.
Fast pubertal progression.
Mm-hmm. I mean, clearly, there is a gender difference. I think the boys, in my experience, and also you can see it, although there are very few boys in the publications, are more difficult to suppress. And the results in boys might be, so the boys are more difficult to suppress than girls. Other than that, we have looked, for instance, between idiopathic versus for instance, hamartomas, and although we have not done a systematic analysis between that, it is likely that, for instance, precocious puberty secondary to hypothalamic hamartoma, which are very aggressive and very early onset, might be a little bit more difficult to suppress than the more traditional idiopathic precocious puberty. I've not covered today the etiology of precocious puberty, and what's new, of course, in the field is, of course, the genetics of precocious puberty. To my knowledge, there are no major difference between, for instance, the patients who are mutated, we have an MKRN3 mutation and the idiopathic one, but the patients are still relatively few, and this has not been done really systematically to address whether organic or genetic precocious puberty have different outcomes with treatment, but this clearly has to be done.
Thank you. The next question is in terms of suppression. As you know, in US usually use a high dose. For example, leucoline acetate start with 7.5 milligram every month, but in Japan, Europe, usually we start with 3.75 milligram. The question is more suppression better than just partial or incomplete suppression?
Yeah, it's clear that the Americans, they still use about twice as much leuprolide than the Europeans and the Asians, roughly. there are no differences, I think, in terms of dosage with triptorelin, so that's nicer. If you look at there are very minor differences in terms of level of suppression between the European dose and the American dose of leuprolide. I think so what we tend to do if we have incomplete suppression is to shorten the interval between the two injections rather than increase the dose. We actually very seldom increase the dose rather than shorten the interval.
Okay. Another question about the dose of injection. For example, if we start with 11.25 milligram every 3 months, and it's not suppressed, how would you do? Do you increase the dose, double the dose, or do you reduce the interval of injection?
Yeah, so this is, I'm looking at the chat right now. There is a question 1, which is, what is your recommendation if there is a failure of suppression after a period of well suppression after 3 months triptorelin therapy, which is the same question as the one you are asking. First of all, I think it's very important to document failure of suppression. I know that this is quite variable from one group or one physician to the other. I still like to document suppression using GnRH or any form of stimulation test, because I think it's good when you embark on a treatment to make sure that the treatment actually works. If there is a real failure of suppression after 3 months, we tend to decrease the interval rather than increase the dose. So that's what we do. We decrease the interval. So for instance, instead of 12 months, 12 weeks, we do 10 weeks. But we do not increase the dose.
Do you have any data on reducing interval from 12 weeks to 10 weeks?
This is a good question. We should probably review that, because this is something that we very often discuss at our rounds in the department, but we have never recapitulated the data. And this is a good question, and I think we should recapitulate that and see whether we have any data to really support that. Yeah. The 7 kilogram CPP boy, which is question 2, in small children below 10 or below 15 or 20 kilogram, we use a half dose. This is what we use. So we rather than 11.25 for 3 months depot, we use 5.5 milligrams. So we use half dose in we would use half dose in a 7 kilo boy. So that was question 2 in the chat.
Another question, Professor Kaleo. In the past, we know that when we give long-term GnRH analog treatment, we suppress gonadotropins, but the level of alpha subunit continue sustain elevation. Are there any concern in long-term?
Um, are you mentioning the stimulation of the alpha subunit? Is that what you're?
Yes, right.
Is that what you're mentioning? This has always fascinated me. Actually, I agree that this is a very intriguing question, and this is something that we often discuss with Julien Léger and the rest of the group. That actually, when you give a GnRH agonist, you do not suppress the pituitary. You actually activate it, but you activate it in a strange way, so to say. And after actually you reset it to make more alpha subunits and less beta subunits. So it's not, the term of suppression is actually not appropriate, so to say. And I thank you for the question.
Do we know the molecular mechanism behind stimulation of alpha subunit, but inhibition of gonadotropin?
I know that this has been addressed in cellular models, and I think this has to do with the cyclic AMP production by the GnRH receptor in the pituitary gonadotropic cell that actually drives the transcription of the alpha gene and the beta genes differently. But this has also a practical consequence because you know that of course the basal LH is often used for the diagnosis of precocious puberty, and although the threshold is quite discussed, if you have a girl, let's say with a basal LH of 1, you don't need to do a GnRH agonist test because I mean you know that 1 is already high enough to make the diagnosis of precocious puberty. Of course, in a clinical context where the diagnosis is plausible. But in contrast to that, this basal LH level is very misleading under treatment. And actually, girls and boys who are treated have a basal LH, which is slightly higher, around 1 or 1.5, but that is not with a response to GnRH analog that is suppressed. So, and this is basically the same story as the stimulation of the alpha subunit. So it's actually the gonadotropic cell is its physiology is really changed by the continuous stimulation by the GnRH agonist. So when we analyze the hormonal results, we should not analyze the result under treatment similarly to the analysis that we do for an untreated individual.
Thank you.
I hope I'm clear.
Thank you. Any more questions, Professor Panaja?
I have a few questions for you. Okay, first question. We now know that 11.25 milligram every 3 months is, it's less frequent injection and sounds to be a good idea, and we have used this for a long time. So is there any situation that you would select 3.75 milligram every 4 weeks? Is there any clinical situation that you would use that?
In terms of clinical practice, some people like to start treatment with the monthly injection and then to switch to the tri-monthly or 6-monthly injection. I personally tend to use directly the tri-monthly or the 6-monthly injection. Personally, I don't really think that there are a strong basis for that. Right.
And so far, is there any final height outcome data in terms of direct comparison between 3.75 milligram every 4 weeks and 11.25 every 3 months?
No. That's a good question. I think having adult height data on a larger population of patients with some treated with monthly, some tri-monthly, etc., and looking whether there is a difference would be interesting. But no, there's no data like that.
All right, thank you. And the last question is that in terms of at the time of discontinuation of GnRH analog, how would you tell parents regarding the height gain after discontinuation of GnRH analog for boys and girls?
Yeah, this is a good question. What I would say, I would be very cautious with what I say, because the experience is that actually the height gain after stopping treatment is not a full pubertal spurt, because actually part of the pubertal spurt has already been used before start of treatment. If one look at, of course, the spurt after stopping treatment dependent on the bone age advancement at the time of stopping treatment. The average height gain is about 10 centimeters in girls. In boys, it's less clear, but in girls, it's about 10 centimeters between height at the time of stopping treatment and adult height after cessation of growth. But this will, of course, vary with age and bone age.
Thank you very much. I agree with you that it's very hard to tell exactly, or even using the bone age estimation, I think it's pretty much unreliable. Do you agree with that?
I agree.
Okay, thank you very much. And thank you very much, Professor Carell, for answering those questions. And now it is time for the second lecture by Professor Julian Leach. The topic is update on pediatric hyperthyroidism. So everybody, please welcome Dr. Leach.
Hello, I'm very happy to be with you today, and thank you for this invitation to speak about hyperthyroidism in children. So, you can see here the different causes of thyrotoxicosis in children. And as you know, Graves' disease is the most common cause of thyrotoxicosis, representing more than 95% of all thyrotoxicosis. And the other causes are autoimmune neonatal hyperthyroidism, thyroiditis, exogenous hyperthyroidism, autonomic functioning nodules, and congenital activation mutation of TSH receptor gene or Macunon-Bright syndrome, and it represents very rare cause of thyrotoxicosis. We also know that the incidence is rare in childhood compared to the incidence during adulthood. And in childhood, it represents less than 5% of all thyrotoxicosis. I will concentrate this talk on Graves' disease. And as you know, Graves' disease is due to the production of TSH receptor antibodies. And the pathogenesis is known to be an interaction between genetic background, environmental factors, and the immune system. And, as many thyroid disorders, it's more frequent in women compared to men. And familial form of the disease represent about 20%. You can see here the distribution by age and sex in children. And as you can see, the incidence increased during childhood, particularly during adolescence, with the sex ratio being predominant in female compared to boys. The classic symptom and sign of hyperthyroidism are well known, mostly represented by the goiter and the tachycardia. and severe ophthalmopathy is rare in childhood. In childhood, there is a decline in academic performance and an increase in height velocity with advanced bone age, as you can see here, related to the duration of hyperthyroidism. And we also know that hyperthyroidism affects cardiac and metabolic functions, growth, and quality of life. And there are also other autoimmune conditions which may occur. Biologically, the diagnosis is very easy with undetectable TSH, high serum FT4 and FT3, and highly variable titers of TSH receptor antibodies. The most common association with other autoimmune or susceptibility disorders are with type 1 diabetes, Hashimoto thyroiditis, Turner's, Down, and Dijon syndrome, celiac disease, and vitiligo, and more frequently in adults, rheumatoid arthritis and Addison disease. The first line of treatment is treating medically with antithyroid drug therapy, but we know to keep in mind the potential adverse event of this drug, either with carbimazole or metimazole or propylturacil, mostly minor side effects with skin effects, arthralgia, transient granulocytopenia, nausea, vomiting, abnormality of taste or smell, and arthritis. But these minor side effects represent less than 10% and are mostly transient. And the major side effects are agranulocytosis or cholestatic hepatitis or the teratogenic effect of the drug. The same is for propylturacil with the toxic hepatitis and fulminant liver failure and ANCA positivity. And now the propylturacil, because of the fulminant liver failure, should be avoided in children. Most of these adverse effects, as you can see here in this study, on more than 1,000 children, most of these adverse events occurs during the first month after the start of a treatment. And these adverse events represent, as you can see, in this study, about 18% of cases for cutaneous reaction, 0.5% for the liver dysfunction, 0.4% for the agranulocytosis and neutropenia. And the ANCA positivity in this study occurred only with propylturacil. There is also a dose-related adverse events of antithyroid drug. And you can see here in this pediatric series that the adverse events occurs more frequently when the patient have a high dosage of antithyroid drug compared with a lower dosage of antithyroid drug. So there is two approaches for the medical treatment. The block and replace treatment with a high dose of antithyroid drug with the addition of levothyroxine, and the dose titration is to adjust the dosage of antithyroid drug to achieve euthyroidism without need of levothyroxine treatment. And as we know that the adverse events are dose-related, and there is no evidence that patients under block and replace have more stable thyroid function, and the similar remission rates with block and replace compared to dose titration. We often use the dose titration. So the recommendation of the primary treatment in childhood is to use metimazole or carbimazole at a dose of 0.2 to 1 milligram per kilo per day, with a starting dose depending on the initial severity and avoiding a high dosage. And once the patient is euthyroid after 1 month, the dose can usually be decreased by 30 to 50%. And the block and replace should be avoided. And there is a frequent clinical monitoring during the follow-up every 3 to 4 months. So we know that the major advantage of the anti-thyroid drug therapy is that the normal homeostasis of a hypothalamic pituitary thyroid may be restored, and a period of medical treatment may be followed by freedom from medical intervention. However, we know that a considerable time may be required to achieve remission, and a substantial proportion of patients do not have remission. So there is no evidence-based strategy for the optimal management, and each therapeutic option has associated complications. And most patients are initially treated at least for 2 years with anti-thyroid drug treatment, and there is a debate about the duration of this treatment. We know that fewer than 30% of children achieve lasting remission after about 2 years of treatment, and the current alternative treatments are thyroidectomy and radioactive iodine. So what we learned from adult studies is that there is no evidence to suggest that extending anti-thyroid treatment after 2 years is of benefit. But however, many patients prefer a prolonged treatment with a low dosage, and these low dosage are very safe, and it has been demonstrated by some studies. We also know that thyroid dysfunction during follow-up are more frequent if patients have radioiodine treatment plus levothyroxine compared to the metimazole group. And we also know that long-term outcomes on ophthalmopathy are more favorable with a long treatment with metimazole compared to the treatment with radioactive, which may increase the question is probably we need a more individual approach to treat patients, and one of the main questions is how to predict and possibly reduce the risk of relapse. So I will show you a prospective study that we performed in France, and all patients we were treated with anti-thyroid drug for a long time, for 3 consecutive cycles of 2 years in case of relapse. And you can see here the results after the first cure of 2 years of treatment. We show here are the months after discontinuation of anti-thyroid drug, and here the cumulative relapse rate. And you can see that the rate of remission was at about 30% of remission after 1 cure of 2 years, and remission was defined as euthyroidism after 18 months after discontinuation of the drug. And in this study, the multivariable analysis showed that the risk of relapse was higher for a non-Caucasian patient, for a patient with high FT4 at diagnosis and high TSH receptor antibodies at diagnosis. And conversely, the risk of relapse decreased with increasing the age and the treatment duration. So based on the finding of his study, a predictive score has been generated, allowing to generate three risk curve with three different levels of severity. Those patients with a score between 0 to 3, and the score are based on the initial clinical and biological finding at diagnosis and the intended duration of antiviral drug treatment. And you can see here how the score could be constructed. So when the score is between 0 to 3, the risk of relapse was 40%. When the score was between 4 to 7, the risk of relapse about 70%. And when the score are above 8, you can see that the risk of relapse is almost 100%. So no chance to be in remission. Let me show you an example with a 5-year-old child, non-Caucasian, with high FT4 levels. You can see here 2 plus 2 plus 1, and with intended duration, with serum TSH receptor antibodies at 1, he has a score at 8, so he has no chance to be in remission because the risk of relapse is about 100%. So what could we propose to this child? We know that perhaps we can propose definitive treatment, but patients are mostly very young, and because of theoretical risk of thyroid cancer at this age, it may be prudent to avoid radioactive iodine therapy in children younger than 5 years old. So I will show you the positive impact of long-term antithyroid drug treatment on the outcome of children. And it is the study we perform in France. And you can see here the result of the long-term treatment on the outcome. You can see here the years until the beginning of the hyperthyroidism and the treatment, and here the estimated cumulative incidence rate, and we will focus here on the remission rate. And as you can see, after 4 years, so 2 years of treatment and after withdrawal, we have 20% of remission. And you can see that the rate of remission increased with the years of treatment. After 6 years, 37%, after 8 years, 45%, and after that, near 50% of remission after 8 years of treatment. So in this study, the multivariable analysis also show that the rate of having a personal history of autoimmunity or susceptibility factors increase the chance to be in remission, and another independent predictive factors was the serum FT4 at diagnosis. So having a less severe disease also increase the chance to be in remission in the long term. So in summary, you can see here the prognostic risk on outcome. The unfavorable variables are the biochemical severity at diagnosis, younger age, large goiter, being non-Caucasian and non-compliance to antithyroid drug, which is a main issue also for the long-term treatment. And the favorable variables are presence of over autoimmune condition, older age and a longer duration of anti-thyroid drug treatment, more than 2 years. We have also to keep in mind the clinical relevance of the TSH receptor antibodies. And you can see here the result of a study showing that serum TSH receptor antibodies levels correlate well with disease severity and extrathyroidal manifestation of grave disease. And after a median 3 years of treatment, the decrease of TSH receptor level antibodies are about 70% in grave disease versus 20% only in grave disease with ophthalmopathy. We have also to keep in mind that the TSH receptor antibodies could be used as a remission marker, and it is nicely shown in this Italian study, which show that when the TSH receptor antibodies normalize in the first year, there is a more positive outcome compared to receptor antibodies normalized later during the second or the third year of treatment. Several studies has now shown the impact of the positive impact of a long-term anti-thyroid drug treatment. You can see here a Japanese study in more than 1,000 children also show that the cumulative remission rate increase with the duration of anti-thyroid drug treatment, being at almost 50% of remission after 8 years, as shown in our study in France. And most recently, a prospective and randomized trial also show the benefit of long-term anti-thyroid drug treatment. In this study, after a median of 22 months of methimazole treatment, patients were randomly assigned to either continue low dose of treatment or to discontinue treatment. And you can see here the results. Here, the months after methimazole withdrawal, and the authors show that hyperthyroidism was cured in almost 90% of patients